So while everyone is joining the webinar tonight, just some background. I'm going to do a brief introduction and then introduce Dr. Podesta, who will be taking live questions. So please use the Q&A to ask questions for Dr. Podesta. But I'm going to get to start before I introduce Dr. Podesta and just share a little bit about Psychiatry Defined and some of the programs. And I can share with you my favorite story about vitamin B3. So, and the reason I want to take a few minutes is these are the last few days that Psychiatry Defined, our fellowship, will be taking new clinicians. So we just started in January and we'll be closing in the next week. So we'll share a little bit. Okay, so Psychiatry Defined was started as a goal to try to help. I started with clinicians and then patients and then back to clinicians, but somehow I just felt we all were kind of stuck, not quite knowing where to go, and mental health treatment options and training options were just limited. And so as an educational resource, we set up Psychiatry Redefined for clinicians. I think in the field of integrative and functional medicine, we all have lots of different names, and you can go to anti-aging conferences and integrative and restorative and precision and functional, and everybody's learning something different. I got a slide from the 4 a.m. group, which has been around for a long time, bragging about all the different disciplines they had in their organization, and they didn't have any psychiatrists listed. So again, our goal is to help the field with psychiatric illness and addiction. So we have courses and fellowships and an ADHD intensive and webinars as we do this evening. So here's my story. Dr. Podesta, who's an expert, can share more, but alcoholism is just epidemic and certainly profoundly impacting our health system and our mental health system. So I was interested in vitamin therapy in college before I went to medical school, particularly vitamin B3. And when I heard the story of Bill, the founder of AA, I just wanted to share it. So pretty classic. Bill was born in 1895, family history of alcoholism. Had a rough teenage year, serious depression at age 17 following a loss, trauma, abandoned by his parents. And then he went off to war. So he served as the National Guard. And in the military, he had his first glass of beer. And again, Dr. Podesta can tell you, but that feeling of that first drink for an alcoholic, I found the elixir of life. He left World War I, and he was a brilliant man, but upon returning home to New York, he was unable to graduate law school because he was drinking every night. And he ended up with multiple psychiatric hospitalizations. And it was one where he had his religious experience and then worked with, I forget his name, I think Smith, to just the Blue Book or the Alcoholics Anonymous was founded. But during Bill's recovery and starting AA, he happened to meet my hero and mentor, Abraham Hoffer, who was one of the first psychiatrists to start looking at a biochemical role for schizophrenia. And he, again, he was a PhD in biochemistry as well as a psychiatrist. And he started, understanding the history of pellagra, which is vitamin B3 deficiency. And in the South, in the early 1900s, 1/3 of our psychiatric hospitals were filled with patients that we called pellagrans. And they looked like they were schizophrenic. B3 deficiency, psychosis, is one of the symptoms. It was mostly the poor, because their diet was primarily corn, breakfast, lunch, and dinner. So didn't quite understand the vitamin B3 deficiency, but a little brewer's yeast on the food cured individuals that were, quote, diagnosed as schizophrenia in the early 1900s. So Dr. Hoffer's theory, which is the orthomolecular treatment of schizophrenia, based on his pellagra work, is that very tiny amounts will treat pellagra, the delusions associated, but there are some individuals with schizophrenia that have a much higher need for B3. And he actually did the first double-blind placebo-controlled trial in all of psychiatry on B3 and schizophrenia. It was kind of laughed out of the APA, but there's some new research that actually has demonstrated some genetic defects on vitamin B3 metabolism in schizophrenia. But for our purposes, what Dr. Hoffer realizes B3 has profound influence on brain function and precursor for NAD, which you'll hear about. But this is Bill's story. He stopped drinking because of this religious experience and a higher power. But Bill, the founder of AA, felt terrible. And that's this kind of middle phase here, this withdrawal, negative affect. I mean, he just was irritable, angry, depressed, even though he was off alcohol. So he wasn't binging and he was staying off it, but he had this dysphoric mood all the time. But then he met Dr. Hoffer, and Dr. Hoffer put him on 1,000 milligrams of niacin 3 times a day. And it completely eliminated Bill's dysphoric state. And he was so excited, he did a study with 30 sober AA individuals, all received the same thing. And he wrote about it in 1965. And he and Dr. Hoffer tried to get vitamin B3 therapy into the AA handbook, but they were kind of voted out because they didn't want any pills. And in this little case study of these 30 individuals, he goes through the details of how, again, that dysphoric state coming off the alcohol was relieved by B3, chronic depression, irritability, suicidal ideations. And this is the punchline of my introduction, is shortly before his death, Bill asked what was the one thing he'd like to be remembered for in the history of books. He said that it would be for his promotion of the B3 therapy, not the creation of AA. And I think we all know how powerful AA has been for so many, but B3 was his most important thing that he wanted to remember. So B3 is critical for lots of brain functions, research on traumatic brain injury, anxiety, Alzheimer's and Parkinson's. Our goal in functional psychiatry is to look at all aspects. Nutrition is one of them. And again, Dr. Hoffer, no amount of evidence will persuade someone who is not listening. So I'm glad that we have a group tonight who will listen to Dr. Podesta talk about NAD therapy. So again, I'm going to go quickly. And this, Heather can give you more information. But again, last week we'll be having the fellowship available for this year, 2022. It's 2 years access to hundreds of hours of content. And some of the content is this addiction course that Dr. Podesta put together for us. And each month we rotate through this core curriculum. And there are lots of other courses by Dr. Teitelbaum, Dr. Shaw, Dr. Bongiorno, and more courses coming. So look at the website. We also put on conferences on lithium, binge eating, food addiction, child psychiatry. And here's my last slide, is we have a conference coming up March 4th on the ketogenic diet. So we can give you more information if you're interested, but we've been putting on a couple webinars a month, and this one we're really pleased. I can figure out how to stop sharing my screen, to have Dr. Podesta, who I've known, I don't know, many years now at different conferences, and was fortunate that she was our early faculty member at Psychiatry Redefined. So Dr. Podesta is practicing in New Orleans, board certified adult psychiatrist with a subspecialty in addiction, forensic, and integrative medicine. Her practice, Podesta Psychiatry, with a multidisciplinary collaborative model, nutrition, psychotherapy, acupuncture, and psychiatry. Dr. Podesta's primary focus is integrative health and addiction, a whole health model. She teaches at Tulane and LSU, consulting in court, member of the Alliance for Benzodiazepine Best Practices, and recently re-releasing her incredible book, Hooked, which Heather will put in the chat. This is an updated edition with lots of references and really one of the few integrative addiction books I've seen out there. Dr. Podesta is a distinguished fellow, the American Psychiatric Association, American Society of Addiction. I think we're all kind of convinced that Dr. Podesta both has the skills and the credentials to enlighten us a little bit. And we decided to do a Q&A format because we tend to always run out of time at the webinars. So please put your questions in the Q&A. But I get to start asking Dr. Podesta a few, and we wanted to focus, although I'm sure Dr. Podesta will take the big category of addiction, but really wanted to address NAD, and maybe you can kind of share with the group what NAD plus is and how you use it and your thoughts.
Hi, yeah, hi everybody. So great to see all these names that I know and don't know, and thanks for that great introduction. And gosh, what a great story with Bill W. and his B3. I know that that was his legacy, but I didn't know that he knew that was his legacy. So that was news for me, that he really wanted that to be more highlighted. Well, NAD, so B3 is, niacin B3. NAD is actually kind of a secondary pathway, or niacin is a component of NAD, Nicotinamide Adenine Dinucleotide. And NAD is an essential redox reaction, NADH, NADP, the ATP, ADP pathway. So it's a natural enzyme, or it's a natural molecule in the body that affects over 400 enzymatic pathways in the body. It is related to sirtuins, which are kind of I think the hot topic in the past couple of years for longevity. And so in order to make the sirtuins work, which are basically the cleanup and repair mechanisms, we need NAD. Problem, as we age, as we add toxins, as we don't maybe have enough precursors like B3 or other things that might be cofactors, we lose NAD. The body eats it up because it's using it for these reactions. So the more we have life stress, I was reading an article about obesity today, the more we have obesity, life stress, food stress, high fructose corn syrup toxins, drug and alcohol toxins, lack of sleep, any and all of those things, they deplete everything. And one of the most, I can't say most essential, but in a hierarchy of things that I would say, if you could take, 1 to 5 things, it would probably include NAD, because it is so responsible for energy, for mitochondrial energy, for DNA repair, for gene expression, second messengers, neuroinflammation and immune regulation. So that's my just gist of what is NAD.
And can you maybe share how you use it in your practice? Sure.
Yeah, so for addiction, it's been used in my personal practice, I'll tell you about, but in general, I'll start because it's been used as an IV form for quite some time. It was actually the molecule, like you went through kind of some history, the molecule was actually discovered, I believe, in the 50s or 60s, and that's when they started using it for addiction. And someone, I can't remember his name off the top of my head, I should have that slide committed to memory, had some really great outcomes with addiction and both alcohol and drug addiction. and couldn't convince people to get it going. But it's an IV form is the most accessible, which is usually from a compounded pharmacy. It's not over the counter. And then there's also the availability of lozenges and of 2 formulations for nasal, and then also subcutaneous. So for me, addiction is so problematic, and mental health in general is so hard to treat wholly and holistically and get all of the elements that are missing. And with addiction, as is, deep depression and suicide, when we don't succeed, the failure rate is death. The failure rate, includes overdoses that could be deadly. And that was very concerning for me. So I've always wanted to just look for multiple things, not just NAD, but multiple things to add to my cocktail, to my treatment mechanisms. Because the gold standard of treatment for Western addiction includes MAT, medication assisted therapy, which is great. For some, it includes, psychotherapies, it includes peer support. And even when you do all of those in a perfect system, really only about 56% of those time and time again succeed. And so I like to think about what we can add. So fortunate for me, I live in Louisiana, and unfortunate for hurricanes, but fortunate for this. I have known since my since my psychiatric residency, I've known a couple of folks that really started bringing NAD into the United States 35 or so years ago. And so I consult at a place just an hour away from me that does the IV form, and they have been doing it for many, many years. And so I refer my patients there to get IV NAD. He has trained probably hundreds, if not thousands, of clinicians throughout the world. And I think some of the names that I saw on the attendee list are some that do have training and understanding of the IV form of NAD. But I also use in my office, I use the compounded form of the sublingual. And then I also use sometimes the subcutaneous, which is available as well. And then the nasal spray, or I use something called a sphenopalatine ganglion block, which has been traditionally used in neurology for complicated headache. But we found that using it as a little bit of lidocaine plus NAD has been having really great effects, and we're releasing some case studies and some studies soon, but has had good effects on opioid withdrawal. So just so you kind of think of what we're doing. So in the IV world, there's a handful of practitioners locally that do this just out of the office too, but I don't do that. But in the IV world, we have someone go in, they're intoxicated one day, they go in to begin their withdrawal so they can detox and get IV NAD solution for about 10 days for some, usually 7 to 10 days. And it takes a while because it's a very long drip, not like a IV hydration therapy that you can get a bag in an hour or two. NAD, because it's slow to act, it also can cause some high, what we think is most likely adrenaline. So it causes some heart palpitations in the IV form, only in the IV form. And so you have to go very, very slowly and watch that. Anyway, so it's about a 5 or 7 hour process, depending on your absorption rates. But the studies have shown that when you do IV NAD, that the intracellular NAD level is increased. Whereas when we do loads of other types of forms or precursors like NMN, which I'm sure people are going to ask about, which are over the counter that a lot of people tout, the levels don't increase as quickly or as robustly and don't change symptoms of addiction and withdrawal.
So let me, so lots of questions coming in pretty rapid. So let me just go back for a minute. So that 5 to 7 hour, is it a one treatment? Is it every day, once a week? What's the process for the IV?
So people are doing it different ways. The traditional way that's been taught to me and that's been touted for most people that practice throughout the world using this is about a 10-day consistent everyday drip and so it's anywhere from 500 to 1,000 milligrams per day, depending on what else is going on and how someone responds, and if they're in acute overt withdrawal from one substance or multiple substances, just really individualize the care. But if we had a cookie cutter, it would be I'd say 7 to 10 days of 500 to 1,000, average 750 milligrams in IV drip, and it does take anywhere from, like I said, 5 to 7 hours, or 4 to 6 hours for most people.
And the nasal or sublingual what would be a course of treatment?
Yeah, so the nasal or sublingual is anywhere from 100 to 200 daily, and that can be the sublingual is just a take-home bottle, and for just mental wellness and cognitive sharpness, energy and longevity, I give many of my non-addiction related patients a prescription for this as well. It is a compounded formula. And I'm not going to, I am going to drop the name of the pharmacy that I use, but there are other pharmacies that have good products. So I will tell you now, and I'm sure we'll be asked again, there's a pharmacy that is I believe the first one that worked on it in the United States, and they have great expertise and they check their bioavailability constantly, and it's Archway Pharmaceuticals, Archway Apothecary, which is in Louisiana. But that doesn't mean that anyone else isn't as successful as them. That's just where I happen to go because they're my neighbors. But the sublingual is about 200 milligrams a day, and it takes 3 minutes to dissolve. And I definitely see some people that are in the audience, in the attendee list, that do take the sublingual and are very happy with it for cognitive performance. And I know some people know that if they, on the recovery from Mardi Gras which is right around the corner, is activated with a little NAD sublingual.
So in the integrative world, we get bombarded with new supplements of the day or the week, depending who's marketing it, and our colleagues ask the same question. Where's the research? Where are we with any kind of research on NAD?
Sure. Yeah, the research has been getting more and more since 2014, I think maybe 13 or 14. So Pinnacle study in 2014 showed increased inflammation, which we know with alcohol intake. And then it really, part of the problem was measuring the intracellular levels, and getting biomarkers related to it. And so having anecdotal reports or having case reports is nice, but let's get some both imaging, and also let's get some markers and some data that's beyond subjective and objective, and DSM testing, kind of same that we're always trying to get away from. So big study showed increased inflammation with alcohol intake and decreased NAD with alcohol intake. And when they gave IV NAD, they reversed that within a day. And so that's one study, but let me kind of extrapolate about that, because I think of all alcohol and opiate withdrawal as increased inflammation. So we're learning so much about neuroinflammation lately. So the next study that I think of is, it was a poster presentation, actually. I don't think it got a full publication. If so, I don't have it. But it was about cravings reduced greatly with IV NAD. So that was with alcohol patients, and then with opiate patients, cravings on day 1 were a high, and then by day 2 they were down, and then by day 5 they were down in the 1s and 2s, and then they had enduring effects. By day 10 and 15, the craving, even after the NAD stopped, the cravings were still low, which is the opposite of what happens when you stop an agent like you use buprenorphine for sorry, my dog is greeting the neighbors. Use buprenorphine for opiate withdrawal, and it cuts the cravings very quickly. But then when you taper off of the buprenorphine or stop it, then they come back, not to the height because of some other changes, but they do come back. Some other studies that there's some researchers at Harvard, David Sinclair, who's been really involved in a lot of the bench science about NAD, and he will tout his personal regimen, but then he'll get into the rat, mouse, and worm studies. And so very, very elegant studies going on about NAD and longevity. That's not about addiction, but again, I don't sound like a scientist when I say this. I kind of think of all brain stuff being stuff that can be treated with what we know. And so, when you're talking about longevity, we're talking about aging and toxins and all the things we talked about. And then some other big studies have come out, actually a 2020 study by NAD Brady from, I want to say he's Australian. There's a lot of research coming out of his lab and his group. And I can share this study because it's actually a great, I'll put it in the chat. It's a great, let me find it, overview of the addiction related treatment with NAD. So it's new. I mean, just like what we're talking about, like we've known about this since the early 1900s about nicotine, about niacin, and then we've known about nicotinamide adenine dinucleotide since the mid 60s. And now we know that it works, but we started with anecdotal and now we're moving over to better treatment. Or to better understanding of the treatment. I do want to tout a study that I'm working on with a group about the nasal, and someone asked, do we use NAD in the sphenocatheter? And I do use NAD liquid in the sphenocatheter that's prepared by the same compounding pharmacy. And we have a handful of pre and post, and I've been using the CNS vital signs neurological executive functioning testing pre and post, and so hopefully we'll get some of those reports released, but consistently with just a handful of a small n, but a handful, we've had some very improved results with just sphenocatheters twice a week for 8 weeks or for 4 weeks, and then improved executive functioning with no other changes.
Great. Before we get to some of the questions from the group, the last one that I have is between YouTube and the everything else, the NMN, which I can't pronounce. Maybe you can help me. But where does that fit in, and is that hype or is that part of this important package?
Yeah, I think it's important, and so the whole pathway. It's nicotinamide goes to niacin, goes to nicotinic acid, nicotinamide goes to nicotinamide mononucleic acid, nicotinamide adenine dinucleotide is created, and then so NMN is one of those in that path of precursors. Niacin B3 is part of the precursor system, NMN is part of the precursor system. It's an over-the-counter product. You can buy it. The researcher at Harvard I mentioned, David Sinclair, he touts taking NMN, but he says that when he takes it, he doesn't feel, or when he and his father, they do a lot of personal anecdotes, they don't feel any sort of lift or any sort of change at all, but they do measure their levels, and it does increase levels over time. The more direct way is to take the active product NAD. It has to be either used in a sublingual, not chewable, not a pill, for absorption purposes, and also breakdown, because NAD is a pretty big molecule. And then the IV is the one that actually really does increase the levels intracellularly. So NMN, I wouldn't, if you are a physician and you have access to using IV or sublingual or nasal or subcutaneous NAD from a reputable source, I would lean towards that, because the studies don't show the heightening of the intracellular levels as quickly with NMN. And when we're talking about addiction, we need that quickness, right? Because it's treatment on demand when someone is present and in front of you. Although I do give supplements that might take, 3 weeks to 3 months to do some damage repair and repletion, those are not the things that keep my patients in treatment.
Okay, let's take some questions that are coming in. So I'm a little confused on whether oral forms are effective. So would you say that they can be effective?
They can be effective. I wouldn't use oral alone for something like as deep as withdrawal, but the oral, which is actually, let's not say PO, let's say sublingual. So what I was just describing, the sublingual absorbing buccal, not in the enteric system. It does absorb, and it does have an immediate noticeable effect for those that have a depleted NAD pathway. But I wouldn't use it alone for withdrawal or for a quick craving reduction, because it's not robust enough, but the IV is. And the sphenocatheter seems to be, but those are the studies that we're working on right now.
Someone asked about liposomal NAD for cognitive function.
Yeah, absolutely. So that's what I'm talking about, the liposomal NAD in the sublingual form. And there are over-the-counter products made by, Silicon Valley investors are big on some of the over-the-counters. Their purity and their bioavailability is going to be a lot lower than a compounded pharmaceutical, as you well know. But that doesn't mean that that's not going to have some effect on longevity and cognitive enhancement. Does it have something as severe for, opiate withdrawal? It does not. So think about who your audience is, who your patient is, and what the needs are.
Okay. Is sublingual, here's a trick question, NMN as effective as sublingual NAD? And part two, are there cofactors that might help absorption?
Right. So we're talking about part of this is the glutathione pathways. So you want to just think of, just like you're doing with all of the other glutathione enhancements, think of this as part of that whole system, although NAD also has some standalone pieces because it does affect like 400 different pathways. And sirtuins in particular. So I would say, I don't know data on NMN absorption at all. I don't know that. What I have heard anecdotally from my patients is what I'm saying is that the sublingual NAD has a noticeable cognitive sharpness and recovery effect. And for those patients that came to me and had been taking the sublingual or oral NMN, they didn't have that noticeable effect. Now, that I'm not saying it doesn't. I'm not able to say that because I don't think that there's certainly not head-to-head research. I don't know what the absorption and PK studies are on the sublingual NMN.
Great. So once someone completed IV NAD, then doing okay, do you have maintenance, or how do you keep levels adequate?
Most of the folks that go to, it's called Springfield Wellness. That's where I learned about this, and that's where I consult. It's in Louisiana. And most of the folks that come there and get the full course of treatment go through opioid or alcohol, usually opioid or alcohol, some other drugs as well, but it seems mostly attracted to those with opioid and alcohol addiction. Get through. Some people go back and get boosters every 6 weeks. Most people take the oral or the sublingual rather in between. And then some people come to me and get the sphenocatheter as a booster, maybe once every 2 to 4 weeks. Some people, sync if they kind of skip out, but some people just have had one course of treatment and then they're done. So again, this is the collective anecdotes that make our early stages of functional and integrative psychiatry tick. We want more data, obviously.
How about for benzos or other detox meds?
I've had 3 or 4, I'm on the benzodiazepine alliance, which is best practices for benzo, trying to help people taper off. It's the hardest thing I've ever done, Jim. Like, it's troubling. If anyone wants to come on board with me, come help. That'd be great. The benzodiazepines are very hard, and there's so much variability with folks and their kind of long-term benzo damage that I don't think NAD alone is the answer. But I have had, actually, someone just emailed me yesterday, someone that we did a 10-day, actually he ended up staying for 15 days. He'd been on benzodiazepines and had benzodiazepine injury syndrome. So he had a lot of neurological, central and peripheral damage. And he just emailed me saying he was doing great. He did those days, and then he has been taking the sublingual ongoing for about 1.5 years. I've had a couple other people who I've recently just done the catheters to help with the benzos and the very detailed taper. Some of the tapers, take 3 years, 5 years, 7 years, plus other augmenting medications and supplements. And the NAD helped a lot. And we even did the cognitive performance to see the pre and post with the NAD. And that was definitely a game changer, but not the only game changer. It needs to be synergistic, just like the slide that you showed.
So a couple questions on someone taking B3. Could they also do NAD? And are there kind of over-the-counter supplements that could increase NAD?
Right. So B3 can increase NAD only to a limit, right? So you still have to have the NAD able to be made. So B3 is great. Other glutathione upregulators, tryptophan is part of that pathway. I'm trying to think of what else. I kind of think of the glutathione and methylation pathways in tandem, and so anything that enhances the glutathione methylation as well is great. So your SAMe and L-methylfolate, zinc. I'm trying to think. Of course, your DHA EPAs are going to be relative upregulators of those pathways, and you just have to have everything in tandem. So it's not just, you don't, to fix the engine of the car, if it doesn't have gas, if it's rusted, if it doesn't have spark plugs, if you don't even have a gas pedal, you can't just put a gas pedal on and make it go, right? So you have to do all of these things. And so frequently, especially with addiction, we have so many depletions and failures of certain pathways from working, and just a lot of toxic damage.
Okay, a lot more questions. What about marijuana and addiction with NAD?
Treating marijuana addiction with NAD?
Yeah.
I haven't had experience, and I would think, thinking about the pathways that seem to be the glutathione pathway, the mitochondrial pathways, energy, thinking about what NAD upregulates, I would say that it's very likely that it could be helpful, but I don't know exactly to what end. Again, I don't have any studies on that. I don't have any personal experience with that. But the fact that NAD is working on mitochondrial energy, oxidative damage repair, DNA repair, genetic expression, like neuroinflammatory regulation. So I think that all of those things in any addiction, in any of the brain stuff, I think that all of those things can be useful. to help someone feel better with any sort of, like I said, brain stuff.
Is there maybe a case that you could kind of help us with? Because there are a couple questions someone asked. Does it help with anxiety or depression? Does it help with the resolution of long-term cravings? How would you put it in kind of a
Yeah,
clinical?
how to distill it down. I mean, it seems to be one of the missing puzzle pieces when the folks that I see that have tried so many things and then they finally get onto the IV form, and it seems to be the missing puzzle piece. Does that mean that it helps with exact specific, I mean, we think of global pathways, and in functional psychiatry, functional medicine, we think of root causes and general, not the soil, not the spoiled fruit on the tree or the toxic fruit on the tree, but the actual roots is what we're thinking of. And so I have seen it help with anxiety, but I wouldn't say that it's a treatment for anxiety, because I've also seen it because it also increases adrenaline for some, that it might cause anxiety. I've seen it like rev people up because it's doing the damage repair and maybe it's imbalanced. So I wouldn't use, it's not an anxiolytic. So let me think about a patient who I recently have seen. He has been on opioids. He's in his mid 40s. He's been on opioids on and off since he was a football player in college and had his first injury. Very typical case. Was prescribed for his surgery and then post-surgery. And then, like you said about Bill W., he had that euphoric experience when he had not alcohol for this one, but he had the first opiate and then kept taking it as prescribed. And then, of course, that waned because prescriptions don't last forever. And so then he did fine for several years and then found himself in kind of a terrible relationship and decreased, mood and decreased coping skills, and cravings started setting in. And he was like, I really want that kind of both the energy spark anyway, and the euphoria, calm. So he started finding opiates on the street or from friends, and then from the street, and then heroin, and he has means, so he's been in and out of lots of treatment programs, and he kept going, probably 5 treatment programs in his adult life, and he kept going he's taking buprenorphine. I have him on an injectable on Sublocade at this time. He's been on that for probably since before the pandemic. He's been sober for about 8 years on medication with me. And in 12-step therapy, peer support, good family system. And he just still felt empty. And so I tried many, many things. I use a lot of methylation enhancers. That's usually my first puzzle piece that was missing, but it didn't fit him. He didn't have the genetics that made it be something that was really a necessary puzzle piece filler. We did a bunch of different things, and he finally went up to Springfield and got just 5 days of IV NAD, and just felt like his cognition lifted. He said his taste buds reversed to back when they were like when he was in high school. Everything was more pleasurable to eat, which was interesting. Mitochondrial damage, oxidative damage repair. So think of that. He smoked cigarettes for many years along with his habit of opiates. So that's an anecdote. He's calmer. He sleeps better. It's not a magic bullet, and it's not right for everybody. And it is not available for everybody at this time because insurance doesn't cover it, and it has limited access. But that's an anecdote, that's a patient. And that, when you look at the patients at Springfield, they have anywhere from 5 to 20 patients there at any given time. When you look at when I hear the stories and I interview the patients and I meet the family members, that's a great example of who goes and has success with IV NAD. He's only done the system once. It was at the beginning of the pandemic after he started the Sublocade. He's only done it once, and he takes the oral now when he remembers.
And so someone asked a question about a saturation point. Does everyone have a different saturation point where They stop absorbing it and it's just passed in the urine? Or do we understand that mechanism?
I think that's a little beyond the mechanism that I understand that's been studied and reported. What I can tell you is different people absorb differently based on, just like other supplements. It is water soluble, right? So it's not gonna build up and be toxic. So you're going to excrete it if you have too much, even if you're receiving it IV. But we dose for the IV, we dose depending on people's tolerability, and that has to do with that kind of adrenaline and surge that we find that makes it really hard to tolerate. Kind of makes you feel like you're just kind of gasping or little breathlessness. So we turn the drip down, and however much one can absorb. I know people that can only absorb 250 in a 6-hour period. That's fine. I've had people that can just 750 in a 5-hour period, and they get it all in there.
Any contraindications to the IV?
So there's definitely some concern with hypertension, with cardiac, for the reasons that I just mentioned, for what we kind of see as the side effects. Are they pure 100% contraindications? No, hence the individualized treatment by a seasoned, knowledgeable, not necessarily a psychiatrist, but someone that you have, as far as the medical portion of it. I like to have the folks that I know that do best, that I like to refer people to, have a partnered practice with people like anesthesiologist, or someone that knows how to run a crash cart better than a psychiatrist.
Okay. How do you connect with professionals who take this kind of approach? Is there groups or organizations that are looking at more holistic treatment for addiction?
Yeah, no, there aren't. Although one of the leaders in the field is actually on this right now. Dr. Cass is a leader in the field of holistic and integrative psychiatry. Holistic and integrative addiction from a psychiatric angle and nutrition angle. There are just a handful of us nationwide or worldwide, and we're using holistic and integrative tools in conjunction with medication-assisted treatment, often in conjunction with spirituality, often transformation effects, often. We don't have a network, but I would like to put together a network. So just reach out to me.
Great. Okay, a couple more coming in. What about smoking? Any NAD and smoking?
Yeah, so I've had many folks that just kind of decrease their cigarette intake with the addition of NAD. And part of it is they just feel sharp. And so they don't feel, what I've heard from several, they feel sharp. They don't feel they desire the cigarette, because I think it also might have some effect on the dopamine reward system that the nicotine is trying to satisfy. So decreased cravings for that too.
Great. And what about kids? Any use or research you've seen in pediatrics?
No research in pediatrics at all. I don't even have an anecdote to share with you. I actually asked the Mediers, who are the ones that have been involved with Springfield and have been involved with this for many, many years. And no data. I mean, we could speculate, like with certain disease states, but I wouldn't want to be the first to cross that bridge.
So at that clinic, then they wouldn't treat a 17-year-old who's addicted, or?
So yes, so that is a different story. So kids, I'm thinking pediatric level. Okay. So those, in my kind of experience and training, 16 and up, maybe 15 and up, if they're using heroin, I definitely want to, and they're motivated for treatment and they have the ability, then I will try to work within the means of what I can. And I would probably recommend it for someone of that age if they were kind of a mature minor that had, but we're already using heroin. Because really, when we're thinking about if you can repair damage quickly, let's do it. That's too young to, I guess any age is too young to kind of screw up the brain that way. But it's kind of a beautiful thing if you could do that almost preventively.
Yeah, in my world as child and adolescent psychiatrist, the kids that we're seeing, the suicide attempts and completions are substance abuse is just
Yeah.
a big part of it. And what about SSRI or SNRI withdrawal? Any
Well, for like discontinuation syndrome, do you think that's what the question is regarding?
Yes.
Yeah. It's interesting because NAD, before they kind of retro-engineered it, when they brought it into the country, they thought it was being touted as an amino acid therapy. And so it was like IV amino acid. And many of you that are seasoned professionals in this field may think, oh, I remember that IV amino acid that was being touted as this fancy thing but we know that certain amino acid compounds are so useful for SRI and SNRI, particularly SNRI discontinuation syndrome, to help take people slowly off of the SNRI so they don't get those lovely brain zaps and all of the other things that go with that concept. And so NAD alone probably would have some good effect, but I would say NAD plus some of the other tools that you would use for discontinuation, including high dose amino acid combination therapy, not IV amino acids, oral.
Okay. Well, let's just some of these you've answered. Why don't we take one more, then you can kind of wrap up your thoughts. Do you foresee any challenges to treatment options being more available to patients?
Yeah, I want to talk about this, Jim. Thank you. The good question to kind of start ending on. Treatment, we have more treatment now, but we have more need. The opiate epidemic is beyond. It's worse than 10 or something times worse than it was before pandemic, even though we have more money coming in, we have more attention to access for buprenorphine treatment. But again, the three arms of traditional exquisite treatment, medication assisted treatment, psychotherapy or cognitive behavioral therapy plus peer support, 56% success and abstinence. But what is success? First of all, it's touted as abstinence in most of the studies, not quality of life. And so how can we get to 90% or something that's more akin to cardiac surgery or to now HIV treatment? How can we get to that with this disease of addiction when addiction's getting worse? Now we've got fentanyl. We're about to have like a whole methamphetamine crisis. Plus the addition of benzos that have been ongoing, and we have the addiction to opiates and pain pills and alcohol. Anyway, so there are so many things that are in the talk I do for Psychiatry Redefined for addiction. I talk about every one of these things, including NAD, but there's so many things that we can add from epigenetic support, not just with NAD, but also with lifestyle and stress reduction and supplements. But also we need to think about all of the non-pharmaceutical, the devices such as the ear stimulators, like the cranioelectric stimulators such as the Bridge and the Morph, to take away from the detox without having to put someone on a medication during detox, plus NAD. I'd love to think of a whole slew of other additional treatments, mindfulness-based approaches, acupuncture everywhere. In the 70s in New York, acupuncture was kind of the mainstay of treatment for those with heroin addiction on the streets. It was pretty amazing, and it was working, again, to a degree, not 100%, but add all these things up and we can do better. So where are we going with that? Well, it takes the people on this call. I know some of you are doing it the best you can. it's hard. And some of us would like to do more and have treatment centers that were whole and holistic. There are just a handful of them. They're generally not insurance covered. And they tend to tout one kind of methodology, not a nice holistic approach, and also not necessarily a holistic and integrative and thorough workup. So I'd like to see what Dr. Greenblatt has created as a center for getting this sort of thought process to swell within psychiatrists, because we really are struggling with the diseases, and we have more to offer, but it's not there yet.
No, as you said, we we can do better. So that's our goal. And appreciate that you took the time to share with us. You got a few copies of the book. We're just sold as people are buying it, and so the book is Hooked, and the link is in the chat. I guess there's been a couple questions. Maybe you could just end. Are there over-the-counter brands that you think are better than others in terms of the NMN or any of the other products?
So I've been told that regarding NMN, and really like resveratrol and other things, other anti-aging type of things too, that 1,000 milligrams, and it needs to be white, and it needs to be made by a manufacturer that is a has best practices. So they don't have, because part of the concern when taking supplements from wherever, of course, as you all very well know, is that there can be toxins in there, mercury, iron flex, and so it needs to be white. And then I think it was Dr. Sinclair maybe talking about his own personal regimen. He says that he wants the NMN to taste like popcorn. I don't know. So I don't have the answer. I've never personally used NMN. I've never carried it at my office. I've used the lozenge NAD, but hopefully that can help. And certainly I can answer more questions if you email me.
Great. Well,
And
thanks again.
I want to mention, actually, I'm very excited. Dr. Sarah Fowler says that she has a program called Enrichment with the whole approach, hopefully to incorporate some IV NAD, bridge devices, things like that. My pie in the sky would be so massive, but I haven't seen it anywhere yet. I hope we can have a combined place soon. And thank you, Hyla Cass, for the Alliance for Addiction Solutions. This is excellent for nutrition and integrative therapies for addiction.
Great. Well, thanks again, and we'll bring Dr. Podesta back, and we'll have plenty of other opportunities to kind of ask questions and learn from each other as we have this evening. Thanks again. Have a great night. Take care. Bye-bye.
Bye. Thank you.